Right, we're going to move on now to the work of Flyspec. Dr. Alberto Gregori and Dr. Patricia O'Connor are going to speak to us about the work of Flyspec. Alberto Gregori is an orthopedic surgeon, a trustee of Flyspec, and the chair of the World Orthopedic Concern UK. And he's been involved in global orthopedics for a long time. And he was a missionary surgeon in Zimbabwe in 1985. I know he's very involved in both actively active surgery and also teaching of others. So I know Trish O'Connor is an emergency medical consultant and a pilot, I gather, and very much involved with trauma management. So they're going to introduce us to the work of Flyspec. So over to you. Thank you.
Right. Hello there, everybody, and welcome to Lusaka for this presentation. Can you see the screen? Can you all see a slide on your screen?
Yeah.
Yeah.
You can, that's fantastic. Okay, well, what we're going to talk about for the next 15 to 20 minutes is give you a presentation and some insight into Flyspec, the flying surgical specialty, really that enables life-changing surgery to be brought to the remote and rural areas of Zambia. You've already introduced Alberto. I will be handing over to Alberto halfway through the presentation, and he will actually give you an example of some of the cases that Flyspec assesses and treats on its trips. Really, what I want to do is to give you a comprehensive overview of the service. And I think to be able to appreciate that, you really have to have an understanding, which I think many of you do have, of the geography and the demographics of Zambia. As you know, most of you know, and it's been mentioned before, Zambia is a huge country. It's a very large landmass, and basically would fit the landmass of the UK into its surface area approximately 3 times. And despite that, the population of Zambia is a third of that of the UK. So as has been mentioned, we're talking about a population that is really distributed over a very, very large area. And of course, if you're a healthcare planner, you have to be able to aim to deliver healthcare to everybody within your country. And this is a big challenge when your population is distributed over such a vast area of such a huge country. Now, 56% of the population of Zambia lives in rural areas. Approximately 2 million, I think that's the latest figure, live in the region of Lusaka, the capital city. And as many of you know, the roads and the transport links are very poor indeed. And so, you know, the everyday Zambian relies on the local healthcare worker. They walk to the local healthcare practitioner, and roads are basically the default position, and these are very, very poor. So this has to be kept in mind when we think about how we're going to deliver healthcare to Zambia. What is the need for a service, a flying specialist surgical service? Well, from a financial perspective, if we think in terms of health services and how well Zambia is resourced, less than $4 per person per year is spent on healthcare. Now, how does that stand in the world table of healthcare provision? And at the very top is the United States, with a whopping great $11,000 per person per year spent on healthcare. So it just really puts it into perspective for you. For people in Zambia, referral for specialist treatment is prohibitively expensive, and really, as has already been mentioned, is not an option. And the majority of these people are people who live out in the rural areas, and as Jakob very nicely showed us, that figure is in the region of 74%. Distance is vast, and patients cannot travel from rural areas to access, you know, to the main city areas. I've put a few pictures of the roads in here, and those of you who are familiar with traveling through Zambia will recognize these situations. Really difficult dirt track roads. In the wet season, the roads become incredibly treacherous and convert to small rivers. Potholes galore, even on the tarmac roads. So very, very challenging travel systems within Zambia. Just a word, we finished up the last presentation talking about the brain drain, which is quite interesting. And within Zambia, expert staff tend not to be available locally. And I understand and take on board the fact that yes, there is an internal brain drain, but there is a very significant external brain drain. And one of the priorities of Flyspec is to try and provide teaching and incentive to doctors and clinical officers working within rural areas to stay and to be able to deliver their skills to Zambia, to the people of Zambia. So, of course, if patients can't come to the doctor for the various reasons that we have discussed, then the doctor needs to travel to the patient. And that, in our context, is aviation medicine, is a flying doctor service. And just a few words about how Flyspec started up, the beginnings, the origins of Flyspec. Many of you will be familiar with the name John Jealous, Professor John Jealous, OBE, and will know him. He is a British trained orthopedic surgeon who came over to Zambia in the 1960s as a very junior doctor, and basically went back to the UK to complete his training, and then came back, fell in love with Zambia, and has stayed here ever since. He was a pilot, private pilot, and recognized all of the problems that we've alluded to regarding access to rural healthcare. And he started to deliver specialist orthopedic care to the people of Zambia using his Beach Musketeer, which is the plane he used at the time. He also set up the very valuable MED orthopedic surgeon training at the University of Lusaka, and he has now the great honor of being able to claim that he has trained a minimum of 30 orthopedic surgeons in Zambia. So Professor John Jealous, the founder of Flyspec and basically the father of orthopedics in Zambia. This slide shows you the areas that Flyspec services, the communities served by Flyspec. And these areas are all very far with regard to distribution to all four corners of Zambia. They are both a combination of mission hospitals and government hospitals. And Flyspec, really its number one goal is to enable remote and rural communities to access otherwise unavailable vital surgical services. That is its number one priority. And it does this by providing a regular rotating program of visits to the numerous outreach hospitals. And some of these visits are done on a monthly basis, Kiteti and Chitakalopi and Mukingi Hill. Others are done on maybe a 2-month, 3-month, or even 4-monthly basis. But basically, there is an established relationship with all of these outreach hospitals in the areas, and they have an arrangement in place, and they know when to have patients brought in for Flyspec to see and for patients to receive surgical care. A huge emphasis, as I said, I mentioned before, for Flyspec on teaching, and many of the patients we see are pediatric patients. More than half, 60% of patients are actually pediatrics, and I'll say a little bit more about that later as we go on. But the bottom line with regard to Flyspec is it has proven itself to be highly sustainable over a period of 40 years, which is an incredible achievement. What sort of conditions do we see in Flyspec? What kind of conditions do we treat? Well, there are a few photographs up here, but suffice it to say that the pathology we see is extreme, it's advanced. Much of the conditions, many of the conditions we see result from neglected trauma, untreated infections, severe illness that has not been tended to. And all of this is on a background of chronic infection, HIV, TB, malaria. A lot of pediatric deformities have gone uncorrected. And one of the conditions that we are seeing a huge amount of still is cerebral palsy, really giving you an idea that we have not adequately addressed our challenges that we face with regard to maternal care and neonatal care. Huge numbers of patients with all of these sorts of problems present to Flyspec. The Flyspec team consists of one plastic surgeon, consultant plastic surgeon, and who is also the pilot, Dr. Gregori. And there are 9 orthopedic surgeons who rotate out to the various areas at different times of the year. Now, these orthopedic surgeons have a full-time job, be it either a government hospital job or a private practice job during the week. But they, at the weekend, come together as the Flyspec team with the plastic surgeon and a trainee, rotating surgical trainees, and go off to these remote and rural areas that very much need their input. The teaching side of things really focuses on being able to support not only the local surgeons going, but the trainees. And this concept of give a man a fish and feed him for a day, but teach a man to fish and you feed him for life is absolutely paramount for Flyspec. And it also kits out the surgeons, the local surgeons, with the ability to take those skills and use them in their own practice, be it private practice or government practice in the future. And we feel it helps support, keep local surgeons within the country, because if they have an adequate private practice, they tend not to be so desperate to go to other countries such as Botswana or South Africa to be able to get a higher salary and an improved standard of living as it is perceived. So a typical outreach program, a typical weekend would be that on a Thursday, late on a Thursday morning, Dr. Gregori would finish his clinic at University Teaching Hospital in Lusaka. He would meet up with the orthopedic surgeon and the trainee that he was taking out with him on the visit. And they would then engage on a maybe up to 5-hour flying trip to get to the remote area, the remote clinic that they're going to, the remote hospital. Interestingly enough, on arrival, there's usually a renter crowd, a joyful renter crowd that greets and meets you, which is a lovely experience. And then the hard work starts after disembarking the airplane. And it may well be that the clinic consists of over 100 patients, and the doctors who are on the team may well work well into the late hours or the early hours of the morning, seeing clinical patients to assess them and have them ready for surgery for the next 2 days of operation. One thing to mention here is that the technology associated with mobile phones has made a very significant positive contribution to Flyspec. It is now possible to use WhatsApp to follow up patients for post-operative progress when Flyspec leaves after completing its surgical operating for that weekend. And it's also a great link for support to some of the remote hospitals. If they have problems, they can send photographs, x-rays or queries. So WhatsApp and mobile phones in Africa, and particularly both Malawi and Zambia, actually has made a significant positive difference to helping with some of the healthcare challenges. Before I hand over to Alberto, who's going to tell you about some of our clinical cases, I just want to make a few comments about burns, because some of you may not be aware of what a huge problem burns are in Africa. And the reason for this is that there are so many burns patients, and the injuries are so severe because the majority of people in remote and rural areas cook out of doors. They have open fires, charcoal fires. Many of them are subsistence farmers, and the adults go off during the daytime to tend the land. And small children, like the child you see in the top left picture here, maybe 5 or 6, are left looking after even younger children and left managing cooking near open fires. And of course, children and fires do not go well together. A significant number of the children may have chronic illness and chronic epilepsy from, for instance, previous cerebral malaria. And if a child or an adult, for that matter, falls into a fire while having a seizure, the belief in many African countries is that if somebody has a seizure, they are possessed by an evil spirit or a demon. And if you touch that person, even to pull them out of the fire, that spirit will pass through to you. And so people have generally left and become really badly injured, really badly burned because of this this occurrence that happens if they seize and fall into the fire. So a very, very common occurrence, responsible for a huge number of burns, very, very severe burns. And you can see from the picture on the right, the young girl, she was burned, her torso, her face and her arm. Her chin has contracted down and fused to her upper chest. She has problems with airway, problems with swallowing, problems with eating. She can't straighten her arm because of contractures, and she can't really use her wrist because, again, she has burns contractures. The picture underneath is after a Flyspec visit from Goran, our reconstructive burns and plastic surgeon, and she now is able to move her neck freely, swallow, talk easily, and move her arm. So that's just a brief overview of the background. What I'm going to do now is hand over to Alberto, and you can decide for yourself, is Flyspec worth it?
Hello there. Thanks for the opportunity to talk about Flyspec. It is one of our passions. Some of the things that we see and provide care for range from Noma. Many of you will remember Boy David and Ian Jackson back in the 80s. Noma, Goran has clinics that go up to 20 patients with Noma, where just basic plastic surgery and the ability to feed patients and reverse a malnutrition changes somebody from not being able to eat, becoming more and more malnourished, to having an ability to eat and get healthier and return to a normal lifestyle. So we mentioned burns, and this is not cosmetic surgery. This is plastic reconstructive surgery, where we can take a child who basically is unable to feed, to use their arms, to at least be able to feed themselves and return to school. But more importantly, chronic burns lead to chronic malnutrition and eventual death. So these children are happy because their pain has got a lot better with the treatment, but they also have a future. Cleft lip and palate surgery is also life-saving. When I first worked in Africa over 30 years ago, if you were born, especially as a girl, with a cleft lip or palate, you were deemed unworthy of a dowry and often taken away by the grandmother and left in the bush to die. That's all changed because now with Flyspec and Smile Train and research, the population knows that it's surgically treatable eventually when the specialist comes to the remote and rural area. You've seen some of the burns, and it's a huge challenge. Reconstructing the hand of a burned child will allow that child to go to school and actually function and have a future. Club feet, whilst it's less common in Africa than it is in Europe, if untreated, will give long-term disability in terms of inability to walk, chronic infection in the ulcerated foot, and usually in a completely neglected foot, limb loss. It's very easily treatable if we can train enough people using the Global Club Foot Initiative to manage it simply with plaster and manipulation. But in many hospitals, there is no plaster, there is no padding and cotton wool. Successful treatment, however, if it's late and surgical, allows the child to socialize, walk, and therefore go to school, and eventually to work. This really is life-changing surgery. Neglected trauma is a huge problem in Africa, and it's the same in every sub-Saharan country. It's not uncommon to see a fracture appearing, especially after COVID, maybe a year down the line, with the bone literally sticking out and putrefying. A child, the top right, is just a child we dealt with in Mbala 10 days ago. This child walked on a broken leg for over a year and came with obviously a problem, and they now have a straight leg and the possibility of going to school again. What was highlighted in the Global Surgery Report by the Lancet Commission was that neglected fractures cause a huge major morbidity and loss of livelihood. So it's not just about death as highlighted by the previous speaker, but if you have a fracture as this patient on the left, who's a subsistence farmer with about 20 extended family members, if you're lying in bed on traction for 6 months and the thing doesn't heal, you can't work. A relatively simple operation, which is actually relatively low tech, for example, in Malawi, we've trained clinical officers to do it, can mean the difference between this patient supporting a family and never working again. And that's a successful treatment on the right for a patient in his best Sunday clothes coming back to the clinic a year later. There are huge challenges. There's a basic lack of equipment. In many hospitals, there is no plaster. There are no sutures. Implants do not exist, and the patients have to pay for them, and they can't afford them. So we take all of this with us. Generally speaking, the surgery that's available in district hospitals is the basic surgery, the obstetrics, the caesarean section, the laparotomy for intestinal obstruction. But there is no complex and reconstructive surgery available. And this really holds true for the whole of Zambia. Even in the teaching hospitals where we teach, the standard of care is slowly improving. It's going to take a long time for these standards to rise with reconstructive surgery. And the past few years with drought and famine have challenged the provision of surgical care to the Zambian population. And the economy, especially last year, we had some of our visits were curtailed because the hospitals could not afford to buy food for the patients. And we often actually go to the market and buy eggs for our burns patients because they are malnourished and they won't heal without nutritional support. And you can all imagine the impact that COVID-19 has had in terms of the economy, tourism, transport, and the rest. There is no doubt that district hospitals have minimal resources and they're underfunded. We look forward to that changing with the announcements from the Minister of Health and the new government. We still have to take our own equipment and supplies, and in Bala, our last trip, we had to supply the plaster, the sutures, the dressings, and a lot of the material, and the clubfoot braces which are required. We have a situation where many hospitals in the UK will supply and donate equipment, which is the basic equipment that we need, but it's really expensive to bring it over, and no airline at the moment will fund us for doing that or support us. And the other problem is we have to travel light. Aircraft are weight limited, especially in the heat and altitude of Zambia, and it's really important that with our planning, we know what we need to bring, and our clinical officers or our doctors or our physiotherapists who arrange our visits will use WhatsApp to tell us what to expect, and we can bring specific equipment to help the individual patients we plan to see. In 2019, before the COVID pandemic, we managed to do 1,112 operations. Many of them were major operations, which normally would have to go to Lusaka for. In other words, that would never happen. Patients can't afford that transport. Flyspec is running a budget of about £185,000 a year. The budget's been rising in terms of costs because of the increase in cost of fuel, but it gives us an operation for about $140 on average, a life-changing operation for $140. I think in Britain, our managers would love to see that. There's no doubt that we've learned that specialist surgery, this is not basic surgery like caesarean sections we've talked about in the previous talks. There's no doubt that specialist surgery can be life-saving, life-changing for the impoverished patients that live in these remote and rural areas of Africa. Patients frequently tell me they just can't afford to get to Lusaka for treatment, and they just walk back to the bush, accepting their lot in life. And this surgery does enable people to become and return to being valued members of the society, and more importantly, independent, allowing them to work and support their families. And it's really important that we accept that there are ways of dealing with this in the rural communities. And we have to also be honest with the challenges that we face. I'd be very glad to answer any questions. And more importantly, if anybody wants to contact us, I'm delighted to take email questions and to work with anybody that wants to further these aims, which I think we all have. If we're attending this meeting, we know and love Zambia. Thank you very much.
Thank you so much. Thank you so much, Alberto and Trish, for that. And wow, it's very powerful what you're doing. I was particularly impressed to see that your emphasis on teaching, training, and also on providing some incentive for surgeons to stay in Zambia, which has always been a problem, hasn't it? So, yeah, I really hope that that can continue. If anyone has anything to raise, please put it in the chat box or unmute yourself. But one question I want to just put in, if I may, is for the future, do you see are things expanding? Do you see it growing, or is it going to stay the same? Or how do you see the things going on in the next 5 years?
So we'd like to expand. It's quite interesting. Just like the medical licentiates, we've been involved in training physician associates in the UK for many years. And Trish actually has probably the longest experience in Scotland of physician associates. There is no doubt there's some resistance. There are some hospitals where the underlying teams that look after patients, the physiotherapists, the clinical officers, know that we can help. And then there's an administrative level that feels that they don't want anybody to come and see what is actually happening in the hospitals. And that's a sensitive political tightrope that we have to walk. We're constrained by our income, and we're constrained by the fact that of our 9 orthopedic surgeons, I'm one of them. I'm not constrained by work anymore, so I can go and do more. But the others have to also provide a full-time work at home, so they're time constrained. And what we've done with them is most of them have got 1 or 2 hospitals that they become associated with, and they'll serve on a monthly basis or bi-monthly basis. The next generation of trainees that we've been taking out to some of the hospitals have actually started as they become young consultants. They've moved into that role. So for example, we have Faith and Wamba who have now taken on Mukingi Hill, and we see that expanding. But as part of that, it's education. Many of the surgeons, and it's been touched upon, haven't been well trained enough to do some of the complex surgeries. Part of that is infrastructure, and it's been touched upon before. There's often a lack of anesthetics, there's often a lack of equipment or load sharing, the generator not working. So even if there's surgery scheduled, it doesn't occur. And that's been a huge problem even in the teaching hospitals. We just spent a week up in Ndola teaching very basic things to the doctors, the medical students, how to do the basics. But you know, you're faced with a hospital that has intermittent water, and soap's an issue. And so there's a challenge. So how do we expand? I think education, education, education. I think the medical licentiates is a very valuable role, and they can be, because the medical licentiate that's operating tends to be handed, they've got a good pair of hands, and you can train them to do a lot of the basic surgery, like clubfoot surgery, can be done by medical licentiates. In Malawi, we train clinical officers to do this. So we can expand the role, yes, but it needs money, and it needs time, and it needs resource.
Yeah, thank you. Thank you, yeah. I think, is there something in the chat box, John? No. No? Okay. Many thanks.
Can I ask a question before they go?
Just made it. Yeah, well done, Ken.
Okay. A few years ago, the Zambia Society Trust was able to actually put you in trust with someone who paid for a new engine for one of your planes. How many planes have you got, and are they still working, and are they actually needing any further assistance on that account?
Yes, yes, and yes. Basically, there are two planes that are operated by Flyspec. There's a Cessna 182, and then there's the Cessna 206. Now, Alberto here, being a pilot as well as myself, he's an absolute aviation enthusiast. So I will leave him to tell you about some of the details of the most recent trip of the 206 down to Africa to have an updating of the engine.
So yes, you were very generously, we were helped to get an engine for John's Beach Musketeer some years ago. The Dutch government helped us upgrade to better planes with longer range and heavier load capacity, hence why we now have a 206, which is essentially an aerial pickup truck, and a 182, which is slightly more comfortable aircraft, but carries less load. At the moment, we've just upgraded or had to overhaul the engine in the 182, and that was generously co-funded by Wings of Hope in the US and some donors, both in the UK, World Orthopaedic Concern provided some money, and also we got money from some plastic surgeons in America who have actually come to visit Goran and see what he does. And we basically headbutted them for some money, and they gave us money because we didn't have the money in the coffers to do it. But we managed that. And the BITE Trust has actually just funded the upgrading of, we had landing some of these runways damages aircraft. So we have a lot of what we call rash, where the stones damage the aircraft. The sun is very harsh on the paintwork and the windscreen. So we've just had the 206 return from Africa to after a paint job and repairing quite a lot of the rash that we had. We've got a couple of new tires that we need to buy, and the BITE Trust has also agreed to fund the avionics. Again, the heat and the dust is very harsh in the older avionics. I'm going to upgrade to what's called the glass panel. So at the moment, we're actually reasonably well off in terms of the maintenance. Our next maintenance challenge will be the engine on the 206, which will have time expire in 2024, and that will cost us about $50,000. And we're starting to put money aside for that. It's actually the day-to-day running that's probably the biggest challenge. To expand and do more flying costs about $245 an hour to fly the 206, and just a little bit less for the 182. So to do the trips that we've been asked to increase are, for example, Mansa, Kasama, and Chilonga. These are all 3-4 hour trips, out and back again. And that's going to be a challenge, and we have to sort of use some of the resources that we have in the UK to support that. But again, it's coming. We hope it's coming, but it will be a challenge to get the excess money over and above our $180,000 or so budget. Yeah.
Thank you. Thank you. John, is there anything else in the chat box? No. Thank you again. That's fantastic, Alberto and Trish. Thank you so much for explaining that to it's an amazing program. Thank you. Thank you to all of our speakers this afternoon. We do appreciate your spending time with us. Thank you to you. Thank you for everybody who are attending this afternoon. If you're not already a member of the Zambia Society Trust, I do encourage you to join, and details are on the website. Easy to join, and I would encourage you to do so. We're dead on time, which is amazing. So we're going to close now. We're going to close with KK singing Tiende Pamodzi Nimun Timo Umo, which means let us have one heart, one spirit, and work together so that we can develop. So thank you again speakers. Thank you for all those who are attending, and I look forward to seeing you next year.